Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm Amanda Mixon, president of RhAPP, and I'm very excited to have you with us. Today's episode is IVIG Unpacked, where we're breaking down one of the more complex and often nuanced therapies we use in rheumatology. IVIG plays an important role across a range of conditions, but there's often variability in how it's used in practice. So today we're going to talk through not just the what, but the why and the how, from mechanisms and evidence to practical, real-world decision-making. Joining me today is Laura Hoover, and we're thrilled to have her first appearance on RhAPPcast. Laura, welcome. We're so happy that you're joining us. But before we dive in, can you just take a moment to introduce yourself and share a little bit about your experience and the work you are doing in rheumatology?
Right. Yeah. Thanks, Amanda. I'm Laura Hoover. I am a PharmD and a director of pharmacy, and I specialize in home infusion therapy, particularly immunoglobulin, IV, and subcutaneous administration. My team and I provide immunoglobulin for a variety of diagnoses, ranging from primary immunodeficiency, neurological disorders like CIDP, but also several rheumatology-related diagnoses. I'm glad to be here.
Well, and I have to say, so I met Laura. She practices here in Colorado, and we had a mutual patient that I could not get IVIG for, and she was a rock star and really, really helped me get IVIG for this patient that she just started. And we're both so happy that she was able to get on it after quite the process. So I'm just so excited because, again, it's one of those things where I do think it's really important that advanced practice providers understand, why you might want to choose IVIG, but also, things we should know about it, risks, etc. So that is why Laura's here. And with that, I'm just going to go ahead and dive right in. So to start us off, can you just walk us through briefly the mechanism of action of IVIG and how it modulates the immune system in rheumatic diseases?
Oh, absolutely. Immunoglobulin therapy is an immunomodulatory effect. So we're pretty much providing a broad spectrum of antibodies from many healthy donors. So when we have these high levels of healthy antibodies from healthy donors, it actually inhibits the endogenous production of those autoantibodies. So if the body's not producing those autoantibodies in the same levels as before, then the symptoms of that underlying disease will decrease as well.
We use it in a variety of conditions, right? So, the first one that I think of that works so well is dermatomyositis. But what kind of some of the conditions have the strongest evidence it's supporting its use? And where do you kind of see it most commonly applied in practice?
Well, you called it, Amanda. The strongest evidence of use of IVIG in rheumatology is in those idiopathic inflammatory myopathies. So dermatomyositis, but also polymyositis. It is also can be used in immune-mediated necrotizing myopathy and anti-Synthase syndrome. But typically we use it for patients who have refractory disease, severe muscle weakness, severe dysphagia, and also in those patients that are steroid intolerant. Generally, it's like second or third line and in an adjunct type of therapy, but it can be very, very useful in those patients with those diagnoses. However, most of the use of IG therapy in rheumatology is off-label. Very limited evidence, not super common in clinical practice. And most of the time, you might see it in the hospital as an adjunct rescue therapy or, again, severe and refractory disease. There is some use in lupus. Usually, it's for patients needing rescue therapy or when standard immunosuppressants are really just contraindicated. Active infection and pregnancy are the big things that come to mind there. You can also use it in CA-associated vasculitis, but usually that's only, again, refractory disease, conjunction with traditional treatment, and if that cytotoxic therapy is actually contraindicated. One more would be maybe scleroderma, usually with myopathy overlap or just severe skin involvement. Sometimes we use it in severe refractory adult onset Still's disease and some other conditions that are co-managed with neurology or hematology. It can be useful. Things like Sjogren's, mixed connected tissue disease, autoimmune overlap syndrome, and IgG subclass deficiency.
Super interesting. I actually didn't even know that we used it in all of those conditions or can be used. I mean, I can tell you that my personal experience, if I have somebody with pretty severe cutaneous manifestations, I mean, I feel like it works so, so well. And, to your point, I certainly don't think of this often as like the very first line of what I'm going to give a patient. But I also don't want people to be scared of it because I have to tell you, I previously, have talked to people and even myself up until the last few years wasn't using any IVIG because I just don't think I really understood it or really didn't understood where it was used, kind of also somewhat hard to administer and dose. And so, can you just kind of help me walk through that? Like, what's the approach of dosing and administration? What are some of the pitfalls clinicians should be aware of? I'm sure I've done these myself.
Really, it's weight-based dosing, so not too terribly complicated there. And it really, really depends on diagnosis. Most doses range from zero point 0.4 to 2 grams per kilo per month. Dermatomyositis, polymyositis, we usually see like a loading dose of 2 grams per kilo, and maybe a maintenance dose of 1 gram per kilo after that initial loading dose. The big thing to know about dosing is that these larger doses need to be split over multiple days. The loading dose, that 2 gram per kilo, needs to be over 4 to 5 days. Maintenance dose, usually we can get down to 1 or 2 days. But some pitfalls to avoid are, don't go too fast. The faster that you go, the more side effects you're gonna see in your patients. And then I would also say do not skip the pre-meds. We use Tylenol and Benadryl specifically as pre-meds and also hydration. But we want to make sure that you have those things available to your patients, especially those with those higher doses. Another dosing tip, use adjusted or even ideal body weight for obese patients when the BMI is greater than 30.
Didn't know that. Yeah, that's super helpful. So really we just need to understand like again this needs to be dosed over multiple days. And so you can't give it all at once. I mean it's a lot. And so you really do and that doing it slowly, giving the pre-meds multiple days particularly initially it sounds like is kind of the key to try to prevent some of those reactions that can happen. And as you do start prescribing IVIG sadly, you probably will see some reactions. And also, I think this is a really great place where clinical pharmacists can be so helpful because they can often help us in terms of like how it is dosed and what maybe pre-meds and going maybe a little bit slower and guiding, the infusion team, the nurses on additional things to allow that patient to continue therapy. I, of course, like, let's dive into some of the adverse effects because I think that's really, really important. So, what are the key safety considerations and monitoring strategies clinicians should keep in mind?
Yeah, absolutely. I think that the side effects are really what scare people the most about IVIG treatment. So, and I would be not a great pharmacist if I did not tell you that there is a black box warning for thrombosis for IVIG treatment. DVT, PE, MI, stroke, even retinal vein thrombosis, which sounds really scary, have been seen with IG therapy. These can occur as early as during the infusion to several days after, and the mechanism is fairly multifaceted, and the risk just increases with higher doses and faster rates of infusion. The reason it's thick. IG is a really big molecule compared to other things floating around in your blood. And it's a very viscous solution that we're putting into our patients' veins. It also can potentially activate platelets or endothelial activation. And then also just the volume expansion at the point of the infusion. The higher doses, it's only a 10% solution. So it is a it can be a decently large dose depending on what's for that actual patient. If you have someone at high risk of thrombosis, advanced age, mobilization, CV risk factors, renal disease, diabetes, all the things, consider limiting the rate of the infusion and adding on hydration. There is a newer IVIG product that actually boasts they remove clotting factor 11A, and that may decrease the thrombosis risk. Clinically, we'll see. It's brand new, but it's kind of one of those interesting things that we're trying to decrease risk as much as possible. So that's thrombosis. Other serious side effects are known, but don't necessarily have a black box warning, but they're still very serious. Aseptic meningitis is one, and your patients need to be educated on the importance of emergency care if that develops. Hemolytic anemia is another issue, especially patients with non-O blood types and in those higher doses that you may use for dermatomyositis and polymyositis. In those cases, just regular checks of the CBC if a patient is symptomatic or at high risk. Another serious side effect could be acute renal failure, especially in products containing sucrose. Because of that, the vast majority of the products no longer use sucrose as a stabilizer, but it may not be a bad thing to bring up with your pharmacy if you have a high-risk patient already with kidney issues. It is important to note, though, that kidney injury may occur in patients without risk factors or without underlying kidney disease. So maybe look at baseline kidney function and periodically throw treatment to just keep an eye on it and make sure that there's not something going on underlying. Of course, there's always allergy or anaphylaxis. My nurses will never infuse without an EpiPen or epinephrine readily available. And then there are some other less severe or less life-threatening side effects. Most often, migraine is really the big one. Headache and migraine is kind of almost expected in a lot of these patients. However, a lot of people complain of fatigue, malaise, nausea, even fever and chills, and then sometimes a rash. So it's all really depending on the patient, on how they're going to react to these things. But the migraine, fatigue, those things can be limiting to the patient and really troublesome. So it's something that we really want to keep an eye on and try to decrease that risk as much as possible. It's important to note with side effects that they are dose dependent, rate dependent, and high duration dependent. So if you are controlling the dose, how fast you're infusing, and if you're getting hydration in addition to other pre-medications, then really you're doing everything that you can to help prevent adverse events in your patients.
That is super interesting. And I also think very, very important that we know. I think, I've had patients on dialysis be able to receive IVIG. This is obviously when it's super important to work closely with, again, your clinical pharmacist as well as the nephrologist involved. I had a patient she's actually still getting IVIG for dermatomyositis, but also on dialysis. We had to really figure out from a dosing perspective when she gets it, but also to your point, it was as you said, sucrose free. Yes, that was the big thing that the nephrologist had told me was like that is how it has to be. It had to be a formulation that did not have that. And so, you can use it. You just again have to be cautious with that.
Yeah, absolutely.
Now, and again, you start to mention these things, blood clots, things like that, and it can be awfully scary because some of our disease processes, just having that disease carries a higher risk for thrombosis. Lupus patients, for example, if they have antiphospholipid syndrome. So, if you are considering this in a more refractory lupus patient, obviously we want to make sure that we check those things as well. I have had a patient have had a DVT on IVIG. And so while again, it's important that we recognize these things, would never want somebody to leave this conversation saying, "Oh my gosh, I don't know that I want to ever use that therapy," because it really is a game changer type medication, in my opinion, for some of our more refractory patients. So again, it's just pick up the phone, call the other specialists if there are other specialists involved, and talk to your pharmacist because I think that is just crucial in understanding what strategies you can do to try to minimize the risks.
Yeah, Amanda, you bring up a great point that all those side effects, it can be really scary. But the cool thing about IG is that we know what the underlying risk factors for administration are for these things to happen. So if we are doing our due diligence and really keeping things really slow, hydration, like those big, huge side effects, the risk is minimized significantly. So just knowing that they're there, that it's a possibility, but then also reassuring your patients that we understand the reasons why this happens and we have strategies that we can use to help decrease the risk as much as possible.
Now, I would be remiss if we didn't talk about the challenges of insurance approval, which often make me want to, bang my head against the wall. So, how do you navigate the insurance approval, prior auths, and patient access kind of in real world?
Yeah, it's difficult. I guess big my big piece of advice is find a pharmacy or a service provider who will help you in the fight. Dermatomyositis and polymyositis are fairly easily approved if you have a proven diagnosis, right? If you have the biopsy and that you know that this is what's wrong, it's can be a little bit easier to get those particular diagnoses approved. But most other rheumatology diagnoses, it's off label and it can be really, really frustrating. The best thing to do is document your tried and failed therapies. How severe are your patient's symptoms and what are those impacts on your patient's life? In many cases, the authorizations will go through the appeals process, maybe to peer-to-peer. Expect to write a letter of medical necessity. Some pharmacies actually have people that will help you with that, will help write the letter for you and then give it to you for editing and so you can sign off on it. So it's nice to have those extra levels of support from some of the service providers. It also, it's good to know and to note that it can be more difficult to get IVIG approved for off-label use in the home. So if we're looking at home infusion, it may be more difficult if you have an off-label diagnosis or if the tests for actually proving that diagnosis are a little bit borderline, right? It may be easier to get that approval at an outpatient infusion center or at a hospital infusion center rather than in the home. There are quite a few pharmacies and service providers out there that will help you navigate this process, and some will even do the peer-to-peer on your behalf. But that's just getting it approved by your insurance. The other major roadblock I really would be remiss if I didn't mention is the cost of the therapy. IG is expensive. Every gram was made in another human's body, and somebody had to go and donate plasma, and then the manufacturers had to take all of these people's plasma to make your medication. So if there's coinsurance or a large deductible, a lot of people have trouble affording that therapy. Nursing costs. But the good news is there's often copay assistance programs available. Some brands even have copay assistance available for off-label use. Some are diagnosis specific, but there are some that are not limited based on diagnosis. And there are actually several rare disease foundations that might be able to help your patients afford their care. A good home infusion company will provide financial counseling to your patients and help them find that access to that extra help.
Thank you so much. And again, I can speak from personal experience that yes, your local clinical pharmacist can definitely help you through this process, especially if you are working with like a home infusion company, etc. So what about like misconceptions or knowledge gaps that potentially clinicians have about IVIG?
Yeah. The first thing that comes to mind, there's a subcutaneous option. It was originally developed for people with primary immunodeficiency because it allows for self administration in the home. Those doses are usually much smaller than the ones we use in rheumatology or in neurology. So that was originally developed for that. However, when you use IG subcutaneously, um, you have slower absorption from the subcutaneous tissue into the bloodstream. So the drug levels tend to be more flat, more just not the up and down peaks and valleys. So it tends to show significantly fewer side effects when we administer subcutaneously. Overall, in most of the diagnoses that we've used sub-QIG in, the efficacy is pretty similar. So it's a great option for patients who may have venous access issues, busy schedulers, travelers. I actually have a patient who's on sub-QIG and he takes it on long distance camping trips. So he will self-infuse every other week in a tent. However, it can be difficult with the higher doses because it's a higher volume of infusion. So it's kind of a bit to fit in that sub-Q space. But an experienced IG pharmacist can easily help with feasible options for your patients if that's the way you want to go. Another thing to think about is that IG has a ceiling effect. So higher or more frequent dosing does not always mean better efficacy. And you may need to consider additional adjunct therapy rather than just increasing the dose or the frequency. Some patients, though, do report a wear-off effect. 3 weeks in, they might say that their symptoms are starting to return. And so I would consider more frequent infusions before I would consider increasing the dose. I would recommend very extreme caution if you're considering doses greater than 2 grams per kilo. Rethink your approach just because of the serious adverse events that we know are dose related. And then one more thing, if there are troublesome side effects, one thing to note, there are lots and lots of options on brands. The efficacy of one brand to another is the same, but the patient's response to that brand can be different depending on which brand it is. So one brand, the patient might get a migraine. If they switch to another, they may not get that migraine anymore. So consider switching brands when the side effects are troublesome, especially if they say it's working for their underlying diagnosis. And then the one other thing I really want to make sure people just know about IgA levels. This is a pretty rare thing, but if you have a patient with low IgA and then you give them a product that has normal IgA, there can be a life-threatening anaphylaxis type of reaction. So if you have low IgA, you want to use a low IgA product, which there are quite a few out there. So it's just something to consider when starting someone that's IG naive, that maybe just checking the immunoglobulin levels, look at IgG, IgM, IgA, and just that way you know for sure whether or not you're putting someone at risk.
That is so helpful, and I have to say, for your first few times I used IVIG, I did not do that. Unfortunately, I didn't have any reactions, but now that I have learned that, I always check an IgA before I start IVIG for that reason, because there are the products, that you can adjust based on that. So I think that's really, really important for us to remember. Um, from a clinical perspective, the two additional things that I might add is to remember that when patients are on IVIG, their SED rate can be elevated just because of the IVIG. So just keep that in mind. Again, when you have a patient that you're using on IVIG, you may not want to be checking SED rates. Um, in those patients, and because you're going to get confused. They can be really high, and then you're like, oh, wait a second, that's just because they're on IVIG. So I would not do that. Why that is, somebody explained it to me, and I don't actually really remember, but I just don't. I know to kind of like, if I see that, like to say, oh, well, that's because they're on IVIG. The second thing that I would say is to just remember that when you are dosing somebody with IVIG, like Laura mentioned, you're getting antibodies from lots and lots of different people. So be careful when you are checking ANAs. Be careful when you're checking other various antibodies. You could very easily get a false positive because you're getting these antibodies from the IVIG. So again, obviously really important that we firm our diagnosis before we start this. But for example, if you see a patient that maybe is on IG because they have CVID, and you're then working them up, just be cautious that you really got to use your clinical knowledge base and other things in suspicion, because you could just see, an elevated SSA, or I even had people that have a positive myositis antibody panel because they've already been on IG. And then we're really questioning, does that person really have those antibodies, or did they just get it because they're on IVIG?
Yep, those are really great points to bring up. Absolutely. It's interesting that you mentioned the SED rate. It's just because it's a large protein that we're putting into the body. So we just tend to see that SED rate increase. And you may want to just, if you are going to check the SED rate, maybe wait 2 to 4 weeks after your IVIG, maybe test it. In a lot of our nurses will take labs for our providers right before their IVIG dose. So that's a great time to check IG levels if you're looking at that, but that would be a potential good time to check the SED rate, because that's going to be the lowest level of these extra antibodies at that time. So I would wait at least 2 to 4 weeks after their last IG dose before you check that.
Perfect. So to close, do you have any takeaways or clinical pearls that you'd like to leave our listeners with before we end this episode?
So yeah, several clinical pearls that I think are really important to keep in mind. That number one, diagnosis specific dosing. So your dosing is going to change depending on what diagnosis that patient has. Also, rounding the dose is common. A lot of times we round to the nearest 5 grams just because these are large doses, and that's the smallest vial size a lot of places will keep in stock. Most products are similar in how well they work for your patients. They're all pretty much the same thing made by other people, but the differences are going to be tolerability. So what patients are tolerating, you want to keep them on that if at all possible. And switching to a brand, you're just inviting other side effects to happen. So put back on those insurance companies if they want you to switch, just mainly based on their own formulary. Don't forget your pre-meds. And then one quick thing, IG can actually be a very useful tool in pregnant rheumatology patients. It is considered safe in pregnancy. It's just, and when other things are not safe. And then the last thing, just want to make sure everybody takes away from this, start low, go slow, and make sure your patients are hydrated.
Thank you so much. That was absolutely incredible. And I hope that our listeners get as much out of this as I have. Thanks so much for joining us on this episode of RhAPPcast. A special thank you to Laura Hoover for sharing her experience and practical insights into IVIG. Again, I think this was such an amazing discussion. If you enjoyed today's episode, be sure to explore more educational content through the RhAPP ecosystem. You can access on-demand learning, podcasts, and additional resources on the RhAPP ACE 2.0 mobile app, designed to support you wherever you are in your clinical practice. As always, thank you for doing what you do, advancing the care of patients with rheumatic disease. I'm Amanda Mixon, and we will see you next time on RhAPPcast.